Hello, my name is Greg Stone, and I'm an interventional cardiologist from Columbia University Medical Center and the Cardiovascular Research Foundation here in New York City. And it's a pleasure for me today to have a discussion with my friend Dr. Bernard Witzenbichler from the Charité University Hospital, Campus Benjamin Franklin from Berlin, Germany. And specifically, we're going to talk about a large study that we've recently revealed to the world and now has been submitted for publication, and that's the intravascular ultrasound study from the ADAPT-DES registry. And ADAPT-DES was a very large study in which we were trying to determine in an all-comers population at 11 sites in the United States and Germany the predictors of stent thrombosis with contemporary drug-eluting stents. But importantly, we also have a very large sub-study from this otherwise large-scale registry, which was specifically devoted to intravascular ultrasound. And both myself and Dr. Witzenbichler are large users of IVUS. And of course, as you know, there's been no one killer randomized trial to demonstrate improved clinical outcomes with intravascular ultrasound. So therefore, we did this very large, non-randomized IVUS sub-study of ADAPT-DES. So Bernard, thank you for joining us here in New York. It's great to have you at the Cardiovascular Research Foundation. Why don't you tell us about the IVUS sub-study of ADAPT-DES?
My pleasure. Actually, the primary hypothesis of the IVUS sub-study of the ADAPT-DES trial was that IVUS guidance during PCI with drug-eluting stents results in an improvement in cardiovascular outcomes, in particular in reduction in definite or probable stent thrombosis compared to PCI guided by angiography. The patient subset of the trial constituted basically an all-comer population, which means that elective as well as acute coronary syndrome patients, STEMI or NSTEMI, were allowed to be included with no anatomic exclusion criteria, which means that patients with bifurcation lesions, left main lesions, restenotic lesions, CTOs, or even vein graft lesions were included, as long as at least one drug-eluting stent was implanted. So finally, almost 8,600 patients were included. Of those, 3,350 patients with IVUS-guided PCI, and 5,230 patients with angiography-guided PCI.
So these are big numbers of patients. This is much larger than any other study before.
Exactly. It's the largest cohort ever done with use of IVUS. So the results were the following. First, based on IVUS evaluation, the operators changed the PCI strategy in almost 3/4 of the cases, either to choose longer or larger sized stents or balloons, to use higher inflation pressures, and longer or additional stents in order to correct for stent underexpansion, malapposition, geographical miss, edge dissections, and so on. Second, the use of IVUS was in fact associated with implantation of somewhat larger devices, with a larger final device diameter. So in the IVUS-guided group, the largest device was 3.4 millimeter compared to the angiography-guided group with 3.1 millimeter, which doesn't sound a lot, but if you calculate the luminal area, you realize that this is a difference of 20% acute gain, right, which could make a difference in long run of those patients. And third, and most importantly, as a result in unadjusted analysis, use of IVUS resulted in a 45% significant reduction in definite or probable stent thrombosis and a 37% significant reduction in myocardial infarction, as well as in target lesion revascularization at 1 year. So these are compelling data. As there were some relevant differences in baseline and procedural characteristics between both groups, propensity scores were employed for adjustment to minimize bias between groups, and still IVUS guidance was identified as an independent predictor of lowering the risk of definite or probable stent thrombosis, myocardial infarction, as well as overall MACE. So in summary, half as many stent thrombosis patients, both early and late, occurred after IVUS guidance compared to the angiography-only group. And finally, further analysis of the data showed that the patients at highest risk for stent thrombosis had the most benefit from IVUS guidance. So the greatest absolute benefit of IVUS use was present in patients with acute coronary syndromes, with a gradient of effect from STEMI to non-STEMI, STEMI unstable angina to stable patients. For example, in the STEMI cohort, the rate of stent thrombosis was reduced from 4.2% to 1.7% at 1 year in the IVUS group, which is, I think, impressive. And the same was true when you compare multiple lesions or anatomically complex lesions like bifurcations, left main lesions, to simple single lesions. Therefore, the greatest benefit of IVUS guidance was clearly seen and present in the patients with acute coronary syndromes and anatomic complex situations, which is, I think, a new and very exciting finding.
So this is really important because this study, unlike most earlier studies of IVUS in which there was only stable ischemic heart disease patients, more than half the patients here had acute coronary syndromes, and a lot of them even had ST segment elevation MI. And we know there's a gradient of the risk of stent thrombosis from stable coronary disease to unstable angina non-STEMI to STEMI. And in fact, STEMI, as you know, putting a stent in a ruptured thin-capped fibroatheroma is probably the #1 predictor for subsequent stent thrombosis. And as you recall very well, as the leading enroller in the Horizons trial, we had almost a 5% stent thrombosis rate with bare metal or drug-eluting stents at 3 years in Horizons from putting in stents in STEMI. So that's almost 1 in 20 patients. So most of us think that we rarely see stent thrombosis, but when you stent high-risk cases in acute coronary syndromes, as you say, bifurcations with 2 stents, left mains, et cetera, small vessel diffuse disease, we do get stent thrombosis. So it was striking, and I think worth emphasizing, that there have been many mechanistic studies that have correlated with IVUS what the predictors of stent thrombosis are. And that is, 1, the minimal stent area, or minimal area within the stent. Right? That's the #1 predictor for both freedom from stent thrombosis and restenosis. And #2 are things going on at the edges. So if you have major edge dissections or large amounts of unstented plaque. And in this study, IVUS use led to larger devices, larger stents and or post-stent dilatation being used, and or longer stents, presumably treating the additional area of disease that you often can't see angiographically. So this all makes sense, doesn't it? You know, you would expect us lower stent thrombosis.
Perfectly makes sense, and I think that's an important point, that by using IVUS you don't miss these edges of the plaque. Yeah. You have less geographical miss, and I think it's very interesting to see that not only stent thrombosis rate was reduced in the trial, but also the rate of spontaneous myocardial infarctions not related to stent thrombosis, and this could be by not letting behind in or outflow lesions, which can be clearly identified by IVUS.
Right. Now, it's also important to note these were contemporary drug-eluting stents. So about 2/3 of these were everolimus-eluting stents, and there were also resolute zotorolimus-eluting stents in the mix in about 10% of the patients. So these were not cherry-picking with the first-generation devices that have high rates of stent thrombosis. The overall rate of stent thrombosis was 0.8% within 1 year. So again, not ultra-high, but not ultra-low either. And by the multivariable analysis, it was more than 2/3 reduced by intravascular ultrasound. So let me ask you, what percentage of your cases, your routine cases outside of studies, do you use IVUS guidance in your PCI procedures?
Well, me personally, I'm doing a lot of acute coronary syndromes. Yeah. I'm doing a lot of complex cases, which might be second referrals or something. So for that reason, my usage of IVUS compared to the whole interventionist community in Germany is relatively high. I would say up to 30 to 40%.
So you use IVUS in 30 to 40%. So I think at Columbia we use IVUS in about 50% of the cases. I personally am about 75%, so I'm admittedly biased here, but that's just because I've seen over the years, the benefits. But when you look on a countrywide basis or a continent-wide basis, Europe, the use is very low. right? And it ranges from countries that are 1% or like 3% in Germany to I think as high as 13 or 14% in Denmark. In the United States, the current numbers for IVUS use are about 15% with drug-eluting stents. So still the vast minority of the cases. So why do you think IVUS use is not higher than it is?
Well, it could be that first that prospective outcome data on usefulness of IVUS guidance for PCI are very limited so far. So there is no large randomized trial, and by that, DAPT-DS IVUS Substudy is very interesting because it's by far the largest cohort ever comparing IVUS guidance to angiographically guided PCI. And although it's not a randomized trial, it's just the number or the size of a trial is fascinating. Coming back to Europe, first in the guidelines of the European Society of Cardiology on myocardial revascularization from 2010, IVUS only has a 2B recommendation, only restricted to left main PCI. And for example, in the ESC guidelines for myocardial infarction for STEMI patients, IVUS is not mentioned at all. Although it is stated in the text of the guidelines that undersizing is a very important problem in STEMI treatment, in PCI, primary PCI STEMI treatment. So my hope is that these data might be useful to upgrade the guidelines for IVUS in the ESC guidelines.
Yeah, no, you know, the guidelines are, for better or for worse, driven by randomized trials. And of course, there were like almost a dozen randomized trials in the bare metal stent era, you know, the largest of which was Opticus. And, you know, again, there were limitations with all of these studies. But when you add them up in a meta-analysis, you clearly saw reductions in MACE rate and target vessel revascularization, in particular with bare metal stents. Here in the drug-eluting stent area, we only have one randomized trial, which was relatively small. It was just recently published. It was a sub-study from the RESET study, looking at long lesions that were random with DES that were randomized to IVUS versus not. And there were strong trends, even in about 260 randomized patients, as I recall, for improved MACE, despite being a lot of crossover. When you got rid of the crossover issues and did an as-treated analysis, there actually were reductions in MACE with IVUS. But to do the right kind of study is probably a 4,000 or 5,000 patient randomized trial in the DES era. So I don't know that we're ever going to get to that kind of study. So in that regard, I think ADAPT-DS, which as you mentioned is over 8,500 patients with about 3,350 patients having IVUS, while it's not randomized, it certainly has the numbers to be powered to bring out these differences. So I think we've got to be careful because even the best propensity adjusted multivariable analysis can't correct for differences in unmeasured confounders. Okay, there could also be site-by-site differences, and we've tried to correct for those as well. That was in the final model. Doesn't seem to be important. But to me, I think these data probably are valid, and that's because they go along with the mechanism of what we know. Bigger is better, and in this case, covering all the edge problems is better, and that's mechanistically what IVUS did. And it also was of more use in preventing stent thrombosis and myocardial infarction in the highest risk patients, the ones that you really have the greatest need for. So let me ask you, how would you change, if at all, your practice based on these data? And you were the first author of the manuscript that we believe is almost in press. How would you change your practice, if any, and how should others change their practice based on these data?
Well, as you know, as is true for you, it's the same for me. I'm a big believer in IVUS use. I always was a big believer. I already had a relatively high percentage. But for me, it's reassuring that IVUS is very useful. And one conclusion I was drawing from this sub-study for myself is that I'm going to use it even more often in complex situations. Mm-hmm. And I'm teaching my colleagues to use it, for example, in STEMI cases, which is not very often done.
People are nervous about IVUS and STEMI, right? Because they're always nervous that if IVUS makes you use bigger stents or dilate more or cover other areas, you're more likely to get distal embolization. So how do you rationalize that in STEMI?
Yeah, well, I think if there's a high thrombus burden, first you have to try to aspirate as much thrombus as possible, and then you can safely do the IVUS. If you need a balloon at all, just use a very undersized balloon, 1.5, and then it's able to image the artery. And in fact, it doesn't really prolong the procedure. In my hands, it makes the procedure faster because it makes the intervention more predictable, more reliable, and at the end it's faster because I have a clear strategy after I did the IVUS pullback.
It's interesting that you say that because we believe that entirely. It takes all the guesswork out of the procedure.
Right.
You're also able to size not just to the lumen, and when you're sizing to the lumen, we always undersize, especially in STEMI where there's natural vasoconstriction. But when you actually can see the vessel, the external elastic membrane, you can actually see that you can use larger stents, and that's how you can actually make the minimal stent area larger. So we've been big believers always of doing IVUS pre. Okay, either before you do any dilatation or, as you say, after small pre-dilatation, and then you can see exactly where the nearly normal to nearly normal reference segment is and exactly plan your procedure to get the maximal stent area, taking advantage of maybe going within 1/4 of a millimeter or so towards the external elastic membrane. Now, most people, unfortunately, use IVUS just after the procedure. Even the ones that do IVUS, they put their stents in and they say, I'm done, now I'm going to IVUS. And then sometimes they're surprised. It often never looks perfect. They often leave it, but they often don't. And I think that if you use it up front to plan, you're at the end, then you pretty much always use IVUS and you always see it looks great, you know, because you've planned your procedure.
Exactly. And you don't have to risk post-dilatation at the edges of the stent.
Right.
You know, once you already decided the optimal stent size. So and it's safe. There's never a problem with oversizing stents.
That's important. So if the reference lumen's like 3 millimeters, people say, okay, so you show me that the external elastic membrane's 4 millimeters, but the reference lumen, which has some disease in, is 3 millimeters. So how do I put in a larger stent than a 3 millimeter stent and not cause edge dissections? And the answer is you put the 3 millimeter stent in reference to reference, but then you use a shorter, larger balloon. We usually split the difference between the reference and the external elastic membrane. So in this case, a 3.5 millimeter balloon to expand the inner portion of the stent, which was on the lesion. And that's really where you need the larger area because that's where it's most prone to restenose.
Exactly. So my approach is to always stent from healthy to healthy reference segments, which is not always possible, but in most cases it is possible, especially in STEMI cases, it's very often possible to stent really from healthy to healthy. And by that, you choose an adequate stent size, and you only have to post-dilate in between. So you never have a problem with edge dissections. And again, it makes the procedure more predictable.
So, you know, cost is always an issue. And I think, you know, maybe that's the elephant in the room, but I think that's a large reason why these devices aren't being used more, both in Europe and in the United States. In the United States, they're just bundled in the, you know, what we call diagnosis-related groups, or the DRG. And while there is a small professional fee for the physician, you know, it's surprising to me that IVUS is not used more. And my own supposition is that people don't know this data, and or they're not comfortable enough reading the IVUS images and really interpreting it accurately. The question is, when is more information worse? And the answer is it's worse if you make the wrong decisions and you don't know what you're looking at. So I've always thought we need to do a better job educating people on what the data is and educating them in a very straightforward fashion how to use IVUS to make clinical decisions in the cath lab. Well, look, this has been a tremendous discussion, and I think you know, what we've seen from this very large study of ADAPT-ES in over 8,500 patients, prospective study, 11 centers in the United States and Germany, again, probably about 30 operators, so it's not just one person driving these results, is that the use of intravascular ultrasound was associated with contemporary drug-eluting stents, a fairly marked reduction in both stent thrombosis, early and late, as well as myocardial infarction. No difference in mortality overall, and no significant differences, we should mention, to be balanced, in target vessel or target lesion or vascularization, which trend towards about a 10% reduction, but nothing that we could see as significant. But for the events that really matter, that is stent thrombosis and myocardial infarction, there really was a striking reduction, and again, associated with safely allowing us to use larger stents and or longer stents in appropriate cases, but not just in all cases. So it really lets you target your therapy to the disease that needs to be treated. So for me, this has been a pleasure to work with you and to get to chat with one of the more experienced interventionalists in the world, especially in the treatment of acute coronary syndromes and the use of IVUS. So Bernard, I want to thank you again for coming from New York and participating in ADAPT ES. We hope you've enjoyed this informal discussion, and please, if you have any questions at all, you're always free to contact us at any time. Thanks again.